a healthcare provider to the patient. Is that clear, folks? So if it is a healthcare to the provider, the answer should be countertransference. Okay, because we said patient to the doctor, that should be transference, F, isn't it, folks? So you should be fighting in this question between A and F, okay? But because it says which of the following best explain the resident's response, that become countertransference, okay? Even though the whole scenario might be confusing here, a resident finishing, is finishing up her shift when she received the page that reads, patient in room 121 asking to leave. The patient was admitted 2 hours ago and worsening dyspnea. On entering the room, the resident attempted to engage in a discussion about why the patient is requesting to leave. In response, the patient pulls out his nasal cannula and says, you don't know anything, you're not even a real doctor. So the patient is mad here, okay? Now, the resident is reminded of her father, who has frequently riddled her accomplishment. This line can confuse the people, okay? But she angrily informs the patient that you can't leave and I am ordering haloperidol to calm you down. No matter what they say, the last line will clearly ask whose response is that, okay? So that's a countertransference, folks, okay? Always remember, when you see a question asked this, where is it going? Is it from the doctor to the patient or patient to the doctor? Is everybody clear, folks? Okay. In this question, you could see, she said so good about the doctor because the case is running late. Now she changed 180-degree opposite. That's a splitting personality, okay? This patient has a splitting personality because look at this. 72-year-old woman is admitted to the hospital due to abnormal vaginal bleeding. Uterine cancer is diagnosed and the surgery is scheduled. Following a successful surgery, the patient compliments the surgeon, saying that's brilliant doctor who saved my life. After an uneventful recovery, the patient is ready to go home, right? Until now, everything is good. On the day of discharge, a nurse informed that her surgeon is running late due to an emergency. The patient angrily responds, the surgeon is terrible. So for her, when everything goes well, it's a good doctor. But the minute something is not going the way she wants it, she's turning completely opposite. So that's a black and white. There is no gray zone, okay? So that's splitting, folks. Okay, that's that. Any question in here? How many people or objects are involved here? 3, right? Here is the 3 objects are involved. So simply, it's a displacement. Did we all get this, folks? Right? He's mad at his wife and showing it to the receptionist. So 3 people here, folks. Okay. All right. Very good. A 45-year-old woman brings her stepson in the office for a well visit. She never wanted children due to her unhappy childhood and wishes her marriage did not include being a stepmother to her husband's 5-year-old. So she doesn't like it. In the waiting room, the woman seems excessively concerned when the boy accidentally trips and clearly uninjured. So you see, she really doesn't like, but then she's caring so much. So that's something opposite to what's her inner side, isn't it, folks? So that's a reaction formation. Reaction formation is you do completely opposite to what you think inside. Is that clear, folks? All right. That's reaction formation. Very good. This is a very tricky question. A 14-year-old boy is brought to the office by his parents who are worried about his reaction to their recent decision to divorce. Despite the effort to be supportive and engaging, he has not expressed any feeling directly about the divorce. When the patient is evaluated alone, he shares that he feels his parents are angry with him. Okay, he feels his parents are angry with him, which makes sense, although he cannot think of any instances when they expressed any anger towards him. So there is no history of parents showing anger to him. Okay. On exam, the patient appears sound and reports his mood is fine. So who do you think is really angry? Here, he is angry about the parents. Okay. So he's projecting, but he has insight onto his parents. Here, people can get confused with the reaction formation. Reaction formation should be opposite. He's angry, but he's pretending like he's happy. Is that clear, folks? But here, whatever he feels, he put it on the second person. That's all it is. Okay. So that is a projection here, folks. Okay. So again, he's mad at his parents, but he thinks he put it in a way he feels his parents are angry with him. So it's opposite. Okay. That's a key, folks. Here, all right. Now you see the 19% of the people went to reaction formation. That's the most closest to this, but you have to be careful. Reaction formation has to be opposite, not on the second person. It has to be completely opposite, folks. All right. All right, let's take a look at this question. Which of the following best describe this patient's behavior? 54-year-old man arrives for the appointment with the new physician. At the front desk, the receptionist tells him that the physician is running behind the schedule, give him several forms to complete regarding his personal and family history. The patient politely agrees to fill them out and has a seat in the waiting area. However, when his paperwork is reviewed by a physician, it contained only the patient's signature. So he did not fill anything. Okay. The patient says, I'm sure a doctor with your education can take a good history. He's just mad that he had to wait. Okay. Instead of confronting the doctor directly, he's showing his anger indirectly, which is a passive aggression. Okay. So that. All right, guys. So that's passive aggression. Any question in here? Okay. Can you guys hear me? Okay, here the question, I think I gave the answer yesterday for this question. I told the exact question, right? So she takes the step 1 exam. Now there is no worry of thinking until the results comes. So she decided not to think about it, right? So that's voluntary or involuntary? That's voluntary. That's a suppression, folks. Okay, that's that. All right. So that's defense mechanisms. It's not bad, is it? All right. Now, these scenarios tend to be easy, but sometimes in the exam, they give you ones that very closely. You have to be careful. All right. Let's go to personality disorders because it's associated with defense. It will be easier to go like that. All right. Now, let's talk about personality disorder triads, folks. Okay. There's 3 groups when it comes to personality: cluster A, cluster B, cluster C. Okay. So if you understand those 3, it becomes a little easier to understand all of them. Now, if you see the cluster A, right, that's a personality A type of people. These people are odd and eccentric. Okay, we call it weird people. Okay, because the way they think and the way they work that's what the cluster A. If you look at the cluster B people, they are dramatic, emotional. So it involves a lot of emotional and dramatic forms. Cluster C is very nervous people. They are very anxious and fearful. Okay, so that's the 3 clusters. Now, each cluster has subcategory of diseases. So let's start with cluster A, right? Now, if you see in cluster A, there's about 3 diseases, folks, okay? All personality disorders are important. You need to know it, okay? Important. First one, paranoid personality disorder. See, what is paranoid personality? These people are paranoid that the whole world is watching them. So they think that everybody is watching them, right? So they're paranoid about everything, folks. Pervasive distrust, suspiciousness, hypervigilance, and profoundly cynical view of the world. So that's the idea. I don't think anybody will miss that personality with the paranoid. They think the news is talking about them. Even when they walk, if someone walks behind them on the same street, they will probably think that this person is following me. So they're very paranoid about everything also, okay? So that's paranoid personality. Everybody clear with that? Now, next one, schizoid, okay? Now, when we say schizoid, I want you guys to write it down. These people avoid public. These people voluntarily avoid public. Okay? That's schizoid, right? What does that mean? These people avoid public. Because what happened with these people, folks, they just want to be alone. They don't like to interact with society. They don't like to talk to people. They like to be alone, like this, my room, no windows. You don't talk to people. Hey, I'm proud to accept I'm a schizoid person. Okay, I love it. So when they do that, they think that they have the whole time. Don't write my name next to it, but that's because that's what we do in medical school, right? We write every disease has one person to write there. All right, so that's schizoid, folks, okay? See, prefers social withdrawal and solitary activities and limited emotional expression. So these people, like, it's hard, nobody knows what they do. Sometimes you see, if you live in an apartment, there's always that one apartment. You don't see them outside. They leave early in the morning, they come back late night. You have no idea what they are doing, right? But they are mostly, some people are very successful in that case. They are on their own. They don't want to be disturbed. It's a waste of time to talk to people, right? So that's schizoid, folks, okay? Now, that's why we see these people avoid the public. So that's a voluntary. They have no low self-esteem or anything. They just try to avoid it. So that's schizoid, folks. All good? Now, next, schizotypical. Write this down. Public avoids them. When it comes to schizotypical, public will avoid them because you don't want to deal with this kind of people. Okay. Now, what is this schizotypical? Their eccentric appearance, they have this odd belief or magical thinking. They will tell you their ideas and stories. When you hear, you are like, okay, this is how my day is supposed to start. So that's how magical thinking they have it, folks. Okay. So, and interpersonal awareness included in the schizophrenia spectrum also. So when we say about magical thinking, they will tell you things that is not realistic, folks. Okay. They will tell you things that's not realistic. So when people come in contact with these kind of people, the public will avoid them. They don't want to deal with it. Is that clear, folks? So that's schizotypical, folks. Okay. Now, so these, look at that: paranoid, schizoid, and schizotypical. All three of them are cluster A, odd and eccentric people. Now, just make sure you know to differentiate schizoid with schizotypical, folks. Okay. Schizoid, those people avoid the public. Schizotypical, public avoids them. Is everybody clear, folks? All right. So that's the idea.
I have a question. Is the schizoid one that those people have the flat effect, or is it schizotypal one?
No, with the schizoid, I wouldn't say a flat effect, but you could see limited emotional expression. They would not show too much emotion outside. They might be emotional inside, but they would not show it outside. So see, when you say flat face, it's a normal word, but sometimes you see that on a depression people too. So we don't want to use that word. Okay. So that's that. Schizotypical, no, they will smile, they will do everything. The only thing, you will have a flat effect when you listen to them. So that's a problem with that. Okay. So that's cluster A people. Are we clear with that, folks? All right. Now, cluster B. Cluster B, we said it's dramatic, emotional, and stuff, right? Look at this. There's about 4 diseases in cluster B. Very important, folks, all of them. Let's talk about antisocial. Okay. Now, I know when we use the word in English, antisocial, what actually we mean is schizoid. We tell the people, you are so antisocial, you don't go to parties. In medicine, antisocial mean is completely different meaning, folks. Okay. So if I wanted to tell basically, you don't want to go to parties and all these things, this person is schizoid. They don't want to interact with public. Does that make sense, folks? In psychiatry, when you use the word antisocial, that's a different meaning. Take a look at here, folks. Disregard for the right of others with the lack of remorse, involves criminality, impulse, and hostility, manipulation. Must be more than 18 years of age to get this diagnosed. They destroy properties and all these things, folks. Okay. See, that's the real antisocial. Most of the time they end up in prison or at least jail for a few days. They will have a history of all those things. That's called antisocial, not a really person who doesn't want to party. That antisocial. Does that make sense, folks? So that's why you have to be careful. Now, the key thing, in order to diagnose antisocial, they have to be 18 or above. What if you have a person has all the symptoms or all the features of antisocial, but they are less than 15, then they are less than 18, they get a diagnosis of conduct disorder. So conduct disorder and antisocial is exactly the same disease. The only difference is the age. Is that clear, folks? So when you read a question, I always tell them, anytime you pick antisocial or anytime you pick conduct disorder, pay attention to the age. You could be wrong if you are not careful with the age, folks. Okay. So that's something important. So that's an actual antisocial. So everybody clear with that? All right. Next, borderline. Now, when you see borderline personality, these people have unstable mood, right? They are not in the same mood all the time. They keep switching. Interpersonal relationship, which means they never maintain one relationship for a longer period, folks. They jump from one relationship to the other. Fear of abandonment, impulsivity, self-mutilation, suicidality. These people, it's like it's either their way or no way. That's how they think. Okay. If they don't get what they want, they don't even mind to take their life out. So they have that sense of emotional emptiness. Okay. And female more common than males. And these people have splitting is as a major defense mechanism, folks. Okay, that's very important for the exam, splitting. Yeah. So splitting is the major defense mechanism. And we have treatment, this behavioral therapies and stuff. We will talk about in the pharmacology, what are the different type of behavioral therapy. Okay, so that's borderline. Borderline is considered high yield for step 1 because they could ask you multiple questions. They could ask the defense mechanism. They could check those things. Okay, always remember they will say that unstable mood and interpersonal relationship. That's the key here, folks. Okay. Now, third one, histrionic. When we say histrionic, simply attention seeking. Simply attention seeking. So that's an involvement of attention, folks. They are dramatic speech, emotional expression, shallow and labial emotions, sexually provocative, may use physical appearance to draw attention. See, the idea is attention. They will do anything to get your attention. That's the idea here, folks. Okay, that's histrionic. Last in this section, narcissistic. Narcissistic is basically they think they are the best and they are the only one who knows everything. That's it. Okay. Grandiosity, sense of entitlement, lack of empathy, and requires excessive admiration for this form. Often demands the best and react to criticism. You know, when you meet these kind of people and you find a simple mistakes on them, they blow out with that. They don't like that when you find a criticism, folks. Okay. And that's the idea because they are fragile self-esteem, folks. Okay. So that's the idea here. So that's cluster B. So cluster B, we have antisocial, borderline, histrionic, and narcissistic. Are we clear with that, folks? All right. Now, continue to cluster C. Cluster C, first one, avoidant personality disorder. See, as the word explains, these people avoid everything. Hypersensitive to rejection and criticism, socially inhibited, feeling of inadequacy. But they like to go for a relationship, but they are scared to go. Now, let's compare this with schizoid. Now, schizoid, they don't like to be in a relationship. They don't like to talk, but they don't have a low self-esteem at all. They just don't want to be bothered. But here, they like to go out and stuff, but they're scared. What if they get rejected? Does that make sense, folks? That is the idea, folks, okay? So that's why they're avoiding, because they are hypersensitive to rejection, folks. That's the key here. Whereas schizoid people have no issue with those things, okay? So now you know how to differentiate schizoid with avoidant, folks. Yeah. Now, next, OCD. This is obsessive compulsive. Actually, this is called OCPD. OCPD. Okay. Now is the time for us to discuss what's the difference between OCD versus OCPD. This is two diseases here, folks. Okay. So you need to know what's the difference between OCD and OCPD. Okay. So let's go back a few pages back. Page 586, you have OCD. This is just OCD. Get to that page. Now, let's talk about OCD, folks. Okay, let's break this down. OCD have two things, obsession followed by compulsion. Okay, so what is this obsession, folks? They have this feeling in their mind something is not complete. And when you have that feeling, they get distressed. The only way they could keep the distress down or they could feel satisfied if they do some activity repeatedly multiple times. Okay, a good example I could tell is you park the car and you lock and you click with your key and you know it's locked, but then we click second time again, right? How many people have done this? We park the car and we click 2 times. And you know from the first lock, it made the noise and it locked, right? So why do you think we do it? Because of little distress. What if the car didn't lock it, right? That's why you want to do it. That's technically an OCD, folks. You guys just don't have an extreme version to get diagnosed. That's all it is, right? They were saying that most of the psychiatric disease, what we study, every human has some sort of those diseases in our life. We just don't meet the DSM criteria to be diagnosed, right? We just don't have it. And this morning, I locked the car. With the handle, you could click the button. And then as soon as I walked into the office, I took the key and locked it again. So I did it twice too this morning, right? So human nature, it's just that, okay, I wanted to try it, right? So that's an obsession, recurring thoughts, and it's a feeling, a sensation that causes severe distress relieved by compulsion. Okay, they have to repeat that. Okay, that's what the OCD is. And some people, they don't want anybody else to do it. They have to do it. Sometimes they come to, let's say, to your house to stay. I have a very good friend. I tell this always. He lives in New York. He comes to visit me. He has OCD. So he visits me like every 3 months. That's a contract I have with him. So he comes every 3 months. So he comes from New York on the last Southwest Airlines that comes at 10 o'clock on Fridays. Okay. He comes home around 10, 11 o'clock. He won't go to sleep till 3 in the morning. He cleans my entire house before he sleeps that night. It's not that my house is dirty. It's not. But the thing is, he has this thing. If he doesn't clean that bedroom, he cannot sleep peacefully because he has to feel that he cleaned it. So before I pick him up at the airport, I need to have a Bounty tissue rolls ready when he comes because that's a free labor. You cannot beat that. And not only free labor, he will clean the house with 100% heart. He does a really good job. When you pay money to people, they just do it for the money, right? But he will do it. When I vacuum the room, I will just vacuum around the bed. He will remove the mattress and he will go under the bed and clean. That's called a deep cleaning, right? I don't even do that. So he will do that until 2, 3 in the morning. And then I just lay down in my room. I was like, okay, cleaning started. I'm excited for tomorrow morning. My house is going to look like a museum, right? He does it every single time. So the reason is, I asked him, why do you do that? He says it. Even though the room is clean or whatever it is, if I don't clean it by myself, I cannot sleep peacefully, right? That's just OCD people, folks. And he would go through every door of my house and he will unlock and he will lock it again because he has to feel that he locked the door, right? So that's exactly, he will go to my kitchen and he'll make sure the stove, everything is off. Very paranoid, right? So that's OCD. The only thing, folks, you see the word ego dystonic, that means they know they have this problem. Ego dystonic means they are aware of it. He knows that he has this problem. We go to a restaurant, we will eat, how sometimes you have empty plates on the table? He cannot wait until the waiters to come and get that empty plate from the table. It has to go right after it's done. I cannot handle him more than 3 days. So he comes on Friday and he has to leave by Monday. After that, I can't keep up with him because everything has to be perfect. It's hard, right? But when you see him, he's like, how do I say, very clean, neat looking. You cannot find a mistakes on him. And he was telling me, when you staple the papers, right? The best way to staple is at a 40-degree angle on a paper. And I was like, huh? So he works for Wall Street. He's in finance, right? The idea is, folks, you see how perfect they're trying to be here? I was like, dude, 40% angle, you have to staple it. I said, I barely staple papers. Okay, so the idea is they want to be perfect in every little thing, folks. Okay, but they know this problem. As long as they know they have this, which is a good sign. Okay, so that's that. Now you could see here, this is completely different from OCPD. That's obsessive compulsive personality disorder. So we're going to talk about that. Okay, now here, if you see here, folks, let's take a look here. OCD is that associated with Tourette syndromes, possibly. There's nothing you could do unless you give some medication or training, okay? So there's a subcategory of OCD. We call this body dysmorphic disorder. Preoccupation with minor or imagined defect. Look at this one. They think they're ugly. It's an imagined defect, right? They think they're ugly. The only way they could feel better by doing multiple surgeries. Okay, the only way to do is by multiple surgeries, folks. It causes significant emotional distress and repetitive appearance related to behavior. Okay, it's common also in eating disorders. Sometimes they think they are fat when they are not, but then they keep losing more weight and they become way too skinny with a low BMI and stuff. That's body dysmorphic disorder. So that's the idea. You know, before I started this batch, and I was in Turkey, I was there for hair transplant training. So that hospital where I was, they also do a lot of cosmetic surgeries. Unbelievable how many people come to do their nose. So there was one surgery I wanted to see how they do the rhinoplasty, right? I go there, I look at this girl, I don't see why she needs to get a surgery. I told her, you look so pretty, you don't need it. And my professor was like, why are you telling that? You're losing my business. I was like, she looks pretty, she doesn't need that nose treatment. They were like, no. She's like, no, I need it. In my mind, that's a body dysmorphic disorder. Of course, I didn't tell her that, but you know, that's what it is. Unless they do it, they cannot be relaxed. Okay, so that's the idea, folks. Okay, so that's body dysmorphic disorder. Now, let's go back and compare this OCD with OCPD.
What if the person is trying to change the, for example, he's trying to go out, but then he keeps changing the clothes because he's not satisfied? Is it because he's not satisfied with his appearance, or is he?
Yeah, he's not
he have?
satisfied with the appearance.
Okay.
That's a common boys problem, right? We cannot make our mind straight. That's what it is, and we tried it. And then, yeah, I don't think it's a psychiatric problem. It's a problem in the head that we cannot get it straight. That's all it is. Okay. So I don't think, you know, if you want to put that into a psychiatry, they need to have more information. This is not enough to put it on any criteria, folks. Okay. So that's that. All right. Now let's talk about OCPD here. What is OCPD? Highlight the word egosyntonic. Egosyntonic mean they don't know they have this problem. See, that's bad when they don't know what it is, folks, okay? They don't think they have an issue. See, my friend, he knows he has an issue. When they know it, they know at certain time they have to control it. But when people don't know you know, they have that, then you think you're perfect, isn't it, folks? That's the idea. Their preoccupation with order, perfectionism, they try to be perfect. Impossible, guys. Nobody can be perfect in this world, right? Now, I always tell OCD people at least become somehow successful. OCPD people, it barely can become successful. Why? I'll tell you a good question that came on the exam, okay? This student is in college, and he always tried to do the final thesis project multiple times to make it perfect. And by the time he finishes it, the deadline is already passed and he failed the semester because he didn't submit the work on time. That is a OCPD because he's trying to do it perfect and he's taking more time, but he never submit that. Is that clear, folks? So but if you talk to them, they don't accept they have a problem. That's the key, because OCD people knows they have a problem and they know somewhere they need to stop this. Is that clear, folks? But OCPD is not like that. They think they are perfectly fine and they will just want to keep doing. Like I came across one student in my life in the last 9 years. This student said that he would not go take step 1 exam unless he knows first page till the last page of the first aid, in and out, word by word. So basically what he wants, if I tell him 147, he should know what's on page 147. I was like, is it magical thinking or OCPD? Right? Because why? Impossible. Who can study like that, folks, right? Nobody can remember. So what happened? They keep studying until they think, and they never end up taking steps. It takes so long, right? He comes back to me almost after 2 years and said, I'm still not taking the step 1. I was like, I knew that from the day one. Unless you fix that in your mind, because nobody can study 100% first aid and remember every single word of it, folks. And if you think that you're going to try it, you will keep trying it. You will never achieve it. The time will fly by. Is that clear, folks? So that's OCPD. They don't know they have a problem. That's a part, folks. It's very hard when you explain them. When you try to talk to them, they will think that we are idiots. They are smart. Because why? They think they don't have any issues. Is everybody clear, folks? That's the idea, okay? So that's OCPD. So OCPD, they don't know what they have it, but OCD, they know it, okay? So that's a different, folks. Is everybody clear? That, and then, most of the psychiatric problem, they don't think they have it. They don't know they have it, folks. If I come and ask you, do you think I have this disease? The answer is no, because I'm already asking myself, right? Most of these people will never even think that there is something wrong with them, okay? That's the idea. All right. Now, last one, dependent personality disorder. Now look at the word dependent, right? Now, when it comes to dependent, their excessive need for support because they depend on someone. Submissive, low self-confidence. Most of the time, patient often get stuck in abusive relationship. Now, when you see people, why sometimes they are stuck in abusive relationship? Because they are so dependent, no matter what, they have to stick to that person because when they come alone, they don't know what to do. So that's the idea here, folks, okay? Now, I was told in the psychiatry, whenever we meet people with dependent personality, you meet a lot of them, right? People come and complain about getting stuck in a relationship and stuff with the abusive. You never advise them to leave that person, okay? So when somebody comes and tell that, they are in an abusive relationship, you never tell them to leave, because if you tell them to leave, that put them in danger because they will try to leave and the person can harm them even more. Does that make sense, folks? So instead of that, what you do, you help them to increase their self-confidence. Once you increase their self-confidence, they know what to do and they know how to move out. Is everybody clear, folks? That's very important, okay? So that's dependent personality disorder. Now, all these are personality disorder. It's not difficult, each of them in different category. Is everybody clear, folks? All right. Now, let's continue with this. Let's go here. Next page, malingering. 100% one question either in malingering or factitious disorder. Okay, you have to get one. Malingering, if you see, symptoms are intentional. Motivation is intentional. We call this secondary gain. Malingering people, they do everything for secondary gain. What does secondary gain mean? They want to get some benefit. They want to get some insurance claim, or they want to get some money or time off from work, all those things. That's what secondary gain mean, right? I'm doing everything to get some time off, folks. Okay. Now, if you see here, patient consciously fake, profoundly exaggerate, claim to have a disorder in order to get secondary gain. For example, avoiding work, obtaining compensation, and all these. And people come, in the work and come and tell, oh, I have a back pain. If I have a back pain, I cannot go to work. I need a letter so they could stay home for 2 weeks and get paid, right? That's very common, folks, okay? Now, that's malingering. So secondary gain, they are doing to get some benefit. Is everybody clear? Now, these people have poor compliance with treatment or follow-up. They will not go to treatment or anything because all they want is the diagnosis and a letter. That's it. Then they are done, right? Complaints stop right after they gain. You give them the letter, that's it. You don't see them for a few weeks and they tell their back pain is gone, right? So that's it. A lot of people misuse this in the United States. Now they make it really hard for disability folks. When somebody has a problem, they have to go to the doctor for a certain number of time to even qualify for it. So people who really have a problem will continue. People who's trying to fake, they will give up after a while. Does that make sense, folks? So that's the only way they can approve it. Because some of them are lifetime disability. If you say that, for example, you have a herniated disc or certain things, you do construction work, you get disability throughout your life until you die. So before they do that, they have to make sure this is a true things, right? So that's the idea, folks. So that's malingering and secondary gain. So what they did, people started doing all the symptoms and they said that they cannot keep up with. Now people live with the psychiatric conditions because psychiatric condition is something you could fake it. They cannot identify whether you have it or not. right? So that's all the military people do that to get out of it, right? So that's the idea here, folks. Now, factitious disorder. Now, when you see factitious disorder, I'm going to say this is exactly same as malingering, except this is a primary gain. This is a primary gain. What does a primary gain mean? They are not doing this to get money or any, no, they just like being sick. They like that attention, basically, okay? They just wanted to be in the hospital. Symptoms are intentional. Motivation is unconsciousness because they are not doing it for money, okay? They just like getting the hospital admission and staying in there. Patient consciously create physical or psychological symptom in order to assume the sick role. Highlight that. It's a sick role. They like being sick. That's all it is. And they will get medical attention and sympathy. That's a primary gain, folks, okay? They will do anything to get that. Some people are even ready to go for open abdominal surgery if you tell them. They will be like, yeah, they like that. They like being in that hospital, folks, okay? Now, sometimes what happens is when it comes to factitious, they are faking on them or they are faking on somebody else, like their kid or some senior people live with them. So factitious disorder imposed on self, that means they come with their own body, okay? If you see, we used to call this Munchausen syndrome. Now, predominantly physical sign and symptoms with history of multiple hospital admission and willingness to undergo invasive procedures, folks. If you just tell them, yeah, we found out you have a problem in the abdomen, we need to open up your abdomen, they were like, sure, they're okay with that. Okay, that's. Now look at this, more common in female and healthcare workers. The question will say, this is a nurse or something, and they come up with a different one, folks. You know, sometimes there will be a question, a patient will come with a hypoglycemia. That's very common with the healthcare people, right? When they come with hypoglycemia, you have, they faint when they become hypoglycemia and they get admitted. We have to do a whole bunch of tests. So what do you think they do? They inject themselves with a high dose of insulin. When they inject high dose of insulin, you become hypoglycemic. Because they are healthcare workers, they know exactly what to do. Does that make sense, folks? And then sometime you will see a question. There's a wound in the hand. That wound has culture. When they do, they find fecal organisms. So then now you wonder, how did the fecal organism get into the wound, right? So that's all these things they will do to get the diagnosis. They just like being sick. Is everybody clear, folks?
So it's being sick, not the attention they like?
No, they just like the sick and attention in the hospital, but they are not doing it for any money or anything. That's it. They are okay to lose money, actually. That's what they like. Okay. Now, sometimes what they do, instead of doing it on them, they do it on other people. It's called Munchausen syndrome by proxy. Illness in an individual being cared for, like, most often child or even old adults, is directly caused by physical harming child or fabricated. So they do something to bring their kid or bring their senior people, okay, elderly person, folks, okay. It is a type of child abuse if they try to harm somebody else or anything, folks, okay. So that's factitious disorder. Now, the bottom line to recap, malingering and factitious, pretty much they both are faking, okay? But malingering is faking to get the benefit, secondary gain, whereas factitious is faking to get the sick role and attention, not for any gain benefits. Everybody clear with that, folks? That's it, okay? So that's one. And I'll show you some questions in that. Now here, somatic symptoms and related disorder. You have to be a little careful here. Here, symptoms are unconscious. What does that mean? They are not lying, they are not faking, they are not making it up. These are true symptoms. They actually feel it, true symptoms. And motivation is unconscious, okay? So you would see each of them when we do. Let's talk about somatic symptom disorder. What is the somatic symptom disorder? More than one complaint. They have abdominal pain, fatigue lasting months to years, associated with excessive persistent thoughts and anxiety about the symptom. It can co-occur with some medical illness. Okay. Now let's talk about this disease. When we say somatic symptom disorder, let's think about it. If I come to you and say I'm a patient, I have abdominal pain and I have a pain in my shoulder, and you guys run all the tests, nothing picks anything. That doesn't mean I am lying. I still feel the abdominal pain and the shoulder pain. So they are not lying, but they also feel the pain, but we are not able to find what causing that pain. So think about the human mindset. The minute we cannot find anything, we think, oh, they might be lying. Is that clear, folks? But these people are not lying. They are true. They are telling the truth. They feel the symptoms, but we cannot find what causing it. That's the idea here, folks. That's a somatic symptom disorders. Now, the treatment is basically regular office visit with the same physician. That's all. You keep meeting with them. That kind of reduce the anxiety, make them feel better, folks. Okay, that's the idea. Everybody clear with that? Now, next, conversion disorder. This is also important. Also called functional neurological symptom. Highlight that word. That means they have to have a neurological symptom, nothing else. It has to be neurological specific, nerve-related problem. Unexplained loss of sensory and motor function, often following an acute stress. What does that mean? You could think, let's say I'm sitting here normal, everything is fine. I'm getting a phone call. That phone call give me the biggest stress. After I hear that incident, I cannot move my right arm for a couple of minutes. I cannot move my right arm for a couple of minutes. I'm not faking. Truly, I cannot move. Because of that shock news that went, I cannot. There are histories. I've read some articles. They hear some very sad news. After that, they have a paralysis of the lower extremity throughout their life. They never gain it back. So that's called conversion disorder, folks, okay? So it's a nerve-related symptom that happens after acute stress, okay? Patient may be aware of it, but indifferent towards symptom. We call that, labella indifference. That's a word, but they know, but they cannot differentiate it. So it's just happened after a stressful situation. Is everybody clear, folks? Now, sometime it comes back after a few minutes, and sometime it doesn't. I met one patient in my life when I was a student. I thought he was lying, actually. So this guy had amputation of all 4 fingers in a factory. When they were doing something, the machine cut his fingers. That's fine. It happened 10 years back. He comes to the clinic saying that he's feeling so much pain in his hand, okay? And for me, when I look at it, the injury happened 10 years ago, everything healed and everything. So I thought he's lying, because when they come with extreme pain, what do they want? Pain medication. Is that clear, folks? So that's opioid addiction. So I thought he's trying to get the pain medication, so he's come on with it. Then I went to my professor. The professor was like, no, I know him. He doesn't lie. He gets a pain in his hand once in a while when he has some stressful situations. So the pain he's experiencing, he's not lying, it's true. But there is no way for us to prove whether he's lying or not, because you cannot measure a pain. Does that make sense, folks? But those are called conversion disorder, when they feel some neurological symptom right after they have some stressful situation. That's why these are the things technically easy to fake, because there is no way we could prove that they are wrong. Does that make sense, folks? So we give him a pain medication for 3 days, then he's fine. And then my prof was saying that he will come back 6 months later again with a similar episode. So anything that he experiences something stressful, he can experience that pain. Is that clear, folks? That's the idea, okay? Now, that's conversion disorder.
Dr.
The last one. Yeah.
Would phantom limb kind of subcategorize into conversion disorder or not really?
It's not, because that's a separate disorder, because they don't have it, but they still feel it.
Yeah, exactly. So
yeah. No, I don't think they will put it next to the conversion disorder.
Okay, it's its own category.
It's its own category, yeah.
Thank you.
No problem. Now, next, illness anxiety disorder. We used to call this disease what? Hypochondriasis. Remember that? This is hypochondriasis. So what is this one, folks? Preoccupation with acquiring or having a serious illness, despite medical evaluation and reassurance. So what does this mean? Sometimes you have patients comes in, and a true case that I met, this particular girl was on a high school, not in a college, 3rd year of undergraduate. She came and she said, there's something not right inside of her. skull, basically inside the brain. Okay. She's like, there is some problem I'm experiencing. I want to do a CT or anything. So first time when they come and they tell that, they did a CT, they couldn't find nothing. Everything is clear. What do you tell them? We don't see any abnormalities. Now the problem is they don't have symptoms, folks. That's the thing. And see, it says minimal to no somatic symptoms, right? So what happens here? These patients actually truly believes that they have some illness, but the doctors are not picking it up. Does that make sense, folks? So when we do CT scan, we tell them everything looks normal and you don't have symptom, you don't need to worry. They don't listen. They will go to a different hospital. They will redo the CT scan again. So they are not lying. They are not also telling doctors are bad, but they think they have some tricky, serious illness. Doctors are not picking it up. Does that make sense, folks? So you see, even when I'm telling it, it's kind of crazy disease, because that's what is psychiatry, folks, okay? Because they believe that. It's very hard to make them believe that they are okay, because they always believe that there is something wrong with them, right? They always believe that. Like, for example, think about it. If I say, you know what, I think I have a hypothyroidism because I feel fatigue and all these things, and I'm feeling it. You go do a test, and if your thyroid hormone is normal, there is no need to think about that. But these people, even after thyroid test is normal, they will say, no, there is something is not right on thyroid, but nothing is picking it up. So they actually truly believe something is wrong. Is everybody clear, folks? So all these three diseases, these are true. They are not lying. So that's that, folks. Okay. So that's the illness anxiety disorder, folks. Any question in this section? No? Okay. Now let's go here. 1 second. We did this. All right, let's go mood disorder. One of the big topic. Let's hit that. You know, one of the students asked, what happened to my friend, the guy OCD, when you go to hotels and stays? Sometimes we had to fly together for some meetings. I sit all the way in the back of the plane. I tell him, you sit all the way in the front. I'm not sitting next to you. Oh, because he makes those cabin crews go crazy. I don't sit next to him. So that's what it is. He's a very nice person, but all right. So now, mood disorder, folks, okay? Now, when it comes to mood disorder, it's the mood, right? The mood can be in different level, folks, okay? Let's do in a different way. You don't have to, you could start copying. So I'm going to tell, this is a normal mood, okay? So what do I mean by normal mood? See, as a human, sometimes you're happy, sometimes you are normal, or sometimes you are sad. That's a mood. It fluctuates in a normal range, folks, okay? So that's your normal level. So the mood disorder is a big word. Under that, there's so many subcategories of mood, okay? You have to know what is, major depression, what is dysthymia, what is cyclothymia, all of them. So if you go, we're going to start with the first subcategory, manic episode, okay? So when we talk about manic episode, it's basically abnormally and persistently elevated, expansive and irritable mood, and increased activity or energy. They are super hyper and happy. So where do I put it in my drawing here? I put that up here, folks. So this is normal. This is manic episode. That's normal and manic. Now you could see how high they are. Does that make sense, folks? So if they are high, if they are manic, that means they're extremely happy, right? So that's manic episode. In reality, when do you think it will happen to you? The day you get an email saying that you are matched, you will go through that for first few hours. So that's manic episode, okay? That's the idea. Or even, the step one, when you pass, now the thing is, now it's a pass or fail. And in step 2 CK, let's say you get the score of 245, you will have manic episode. That night, you're not going to sleep. Okay. You will go through all of them. Distractibility. And you have that impulse, inflated self-esteem, flight of ideas, right? You already think about the next steps, all those things, right? So then you have increased goal-directed activity, decreased need for sleep. You don't need to sleep because you are hyper and high energy. So, okay. Talkativeness and preserved speech. These are all episode of manic episode. Now, if you really see, these people are little too much. Now, you also get happy, right? Sometimes, like today is Friday. I don't need anything new. I get happy on Fridays. Okay. Now, only thing is I don't meet the criteria for manic episode, but I'm extremely happy. So that's manic. So that's a manic episode, folks. Okay. Now, most of the time, sometime, any duration if hospitalization is required, folks. Okay. So that's also, you could see, diagnosis requires marked functional impairment with more than 3 of the following or more than 1 week or any duration. See, what's the difference between we being extra happy on a day versus manic? Even though I'm happy, but I'm still doing my normal daily duties and activities. Does that make sense, folks? These people don't do that. That's a difference. If I wake up and say Friday, I'm extremely happy, I'm not going to go teach the class today, that's manic episode because I'm not doing my daily activities or routine, what I'm supposed to do. Is everybody clear, folks? So these people will not. They just wake up and won't do anything, right? That's why it says functional impairment is involved. So that's manic episode. Is everybody clear, folks? Now the next disease, hypomanic episode. So where do you put hypomanic? This is where people get confused. Where do you put hypomanic in here? Hypomanic is little lower than manic, not below normal. Some people think hypomanic means you have to put below normal. No, that's different. This is hypomanic. Okay, so we are going the axis this way. If you go above normal, you are getting through the manic part. Going down is depression. It's completely different. Is that clear, folks? All right. So that's hypomanic. What is hypomanic? Look at this. Similar to manic episode, except the mood disturbances is not severe enough to cause marked impairment in social or occupational functioning. So these people are extremely happy, but they will do everything what they are supposed to do it, folks. Okay. So that's that, folks. Abnormally high activity or energy usually present. No psychotic features, last more than 4 consecutive days, folks. Okay, it has to last. See, if you think about it, we go through this too, but we just don't meet those exact criteria. Some days you guys are happy, some days you are not. We are not in the same every day, right? So that's hypomanic episode. Is everybody clear here, folks? Okay, that's hypomanic. Okay. I'm just doing, okay. So that take care of manic and hypomanic. Next one I want to do actually depression, okay? Major depressive disorder. Where are you going to put that here? The major depression should go up, down here, folks. Depression is opposite to happy, okay? So we are going down here. So we're going to call major depressive disorder. Is everybody clear, folks? So that's major depressions, okay? Very important. Now look at this. What is the major depressive disorder? Recurrent episode lasting for more than 2 weeks, characterized by more than 5 of the 9 diagnostic criteria. So you need to have 5 of these for more than 2 weeks. What are those things? Sleeping disturbances, decreased interest, we call anhedonia. Very important to diagnose that. Guilt or feeling of worthlessness, decreased energy, decreased concentration, decreased appetite, psychomotor retardation, agitation, suicidal ideation. One is missing in this book. You should write down decreased libido. That's also a criteria for major depression, folks. So we have to make sure to screen for previous manic or hypomanic episode to rule out bipolar. It will make sense when I do bipolar, okay? So, but those are criteria for depression, folks, okay? We ask all these questions. Now, once you diagnose, we could do therapy or we could start on medication. We'll talk about those things later, folks, okay? Now, Response to a significant loss may resemble a depressive episode. Okay. See, let's say if somebody close to me die, I'm going to be sad, but that will look like a depression, but it might not meet the criteria, folks. Okay. We're going to talk about the grief. When do we call it normal? When do we call it abnormal in a moment, folks? Okay. So that's major depressive disorder, folks. Okay. Is everybody clear? Okay. Now, there is something, it's a type of major depression we call seasonal affective disorder. It's the same as major depression, but it comes seasonally, not continuously. Especially people go through this when they get into winter in certain states, right? Like if you see, I've seen people that in Chicago that in winter, they're like sad all the time, but when the summer comes, they go to manic episode, right? So that's basically seasonal disorder, folks, okay? Major depressive episode occurring only during a particular season, okay? That's the idea here, folks. More than 2 consecutive years, in most recent years, a lifetime. So what do? There's something called light therapy for these people. There's a places that has a special light. They go sit like a half an hour every week or twice a week. It makes them happy. So that's basically it is, folks, okay? So it's a subcategory of depression that comes during seasonally, folks. Is everybody clear? Okay. Now there's another type of depression. We call this atypical depression. This is an atypical depression. What does that mean? The regular depression, what we talk about, is basically you are not hungry, you cannot sleep, you're like, that's the regular standard depression. Atypical means they are doing everything opposite. They are sleeping a lot, they are eating a lot, everything is opposite, right? People wonder, if you are sad and depressed, why would you eat a lot and sleep a lot? That doesn't make sense. But that's called atypical depression, folks. Look at this. Characterized by mood reactivity. Now, hypersomnia, they sleep a lot. Hyperphagia, they eat a lot, and they just lay down. They sleep, eat, and lay down in the bed. That's all they do. Long-standing interpersonal rejection sensitivity. That's the most common subtype of depression, folks, okay? So we call it atypical depression. So that's atypical depression. Everybody clear, folks? Now, the next disease we're going to talk about, dysthymia. Now they are calling it persistent depressive disorder. But remember, I said dysthymia. Where do you put dysthymia here? This is where we put dysthymia. Dysthymia is a mild depression, put it in that way. Dysthymia is a mild depression. This chart is going to make it much easier, folks, by the time we finish this section. It's so easy to understand. Make sure you guys write it nicely. So dysthymia, you are sad, but not all the way to depression. Is that clear, folks? So that's dysthymia. Look at the dysthymia here. Often milder than major depression, more than 2 depressive symptoms lasting for more than 2 years. That's the idea, folks, okay? That's dysthymia. Everybody clear? Okay. Now in this chart, so we know from the normal, if you go upward, you have hypomanic and manic. If you go down, you have dysthymia and major depression. Is everybody clear, folks? Anybody has any questions so far? Okay. Now here, there's another little disease, major depression with psychotic feature. So it's as simple as the same major depression here. So we cannot add it with his chart. With psychotic feature. What does psychotic features mean? Those are hallucinations or delusions. So keep it simple. Depression with psychotic features mean they're either hallucinating or delusions. That's all it is. So everybody clear, folks? All right. Now, psychotic features are typically mood, depressive themes, okay? They are the guilt, all the symptom with psychotic features, folks, okay? That's the idea. So the best way to do is, I always keep major depression. See, they already have it here. Highlight this. Major depression with either hallucination or delusion, we call psychotic features. Okay, that's that. So this is the main 4 diseases in mood. When the mood is going up, hypomanic or manic. When the mood is down, dysthymia or major depression. Are we clear here, folks? Okay. Now, Let's talk about bipolar disease. Because this is the confusion, you know. I see students, they are always confused how to differentiate bipolar 1 and bipolar 2. Let's make it down. Bipolar 1, more than one manic episode, plus minus hypomanic or depressive episode, folks, okay? So now, where do I put this in graph? I will put it like this. So it can go either to manic, hypomanic, or depression all the way here. So it can go from one edge to the other edge. Is that clear, folks? That's called bipolar 1. That's bipolar 1. So bipolar 1, one day when you talk, they are like a super happy, and 2 days later, they're like super depressed. That's bipolar 1, folks, okay? That's what the book says. If you see, manic plus minus hypomanic or depressive episode, folks, okay? So that's why. So it can go any extreme from both age 180. Is everybody clear, folks? Okay. Now let's compare the bipolar 2. Look at this. A hypomanic and depressive episode. What does that mean? This is bipolar 2. This is bipolar 2. So how do you differentiate bipolar 1 from bipolar 2? Simple. Bipolar 1 has manic, bipolar don't have manic. Is that clear, folks? Only the manic episode is the differentiating factor between bipolar 1 and bipolar 2. All good, folks? All right. So it's not hard, okay? Bipolar 1, always remember, goes from door to door, both sides. Bipolar 2, it doesn't have manic episode, folks. All right. Now there is one more. And, you know, always remember, when people have bipolar, patient's mood and functioning usually normalize between episodes. Don't think they're going to be 24/7 like that. Oh, sometimes you'll meet them, they're like completely normal and perfect. And you go for lunch and come back, they will be super depressed. It will change like that. Okay. So that's why it's called bipolar. Their mood is not in one place, folks. Okay. They could be normal. And one thing I'm going to highlight, you never prescribe antidepressant for this people. If you are wrong in diagnosis and you give them antidepressant, what does antidepressant do? Increase the happy hormone of dopamine. Is that clear, folks? That dopamine can destabilize their mood and they could kill themselves, high suicide risk. So that's why when people come with a mood disorder, we give mood stabilizers. Is that clear, folks? Mood stabilizer is different than antidepressant. You have to be extremely careful. That's a question. Which of the following medication is contraindicated in mood disorder? Or they will give a mood disorder, they will ask you, okay? You never give antidepressant, folks, okay? Very important. Okay, so everybody clear, folks? Now, cyclothymic disorder, the last one here. It's a milder form of bipolar, which means between mild depression and hypomanic. Where do I put that? I'm going to put it here. You see here? That is cyclothymic. Simple. So what is cyclothymic disorder? They are mild happy and mild sad. Is everybody clear, folks? That's what it is. See, that's why I come up with this chart. When you look at this chart, it gives you the big picture of the diseases. See, this gives you better understanding than reading lines of multiple diseases at a different time. So you could kind of see it. This should be on this page, folks. Somewhere you put a note, sticky notes, and attach to it. Before you start studying mood disorder, you should be having this next to you. Okay, that's a chart. That's a good chart, Wayne, for your whiteboard in the back. Every day you look at it. And I would do that because once you have that memory, it makes it easier, folks. Okay, so that's that, folks. Any question in here? Okay, so to recap, patient has normal mood, and if they get extreme hyper, we call it manic, and then where it's mild is called hypomanic. On the other hand, major depression, and the mild depression, what we call dysthymia, folks, okay? Now, bipolar 1 is basically can go to manic or major depression. It could be anywhere, okay? And then we have bipolar 2, same thing, except they should never get manic episode. So before you diagnose somebody with bipolar type 2, it is your job to rule out manic episode. Is that clear, folks? All right. Then cyclothymic, it's mild happy and mild sad in between. Clear here, folks? All right. That's the mood disorder. If you know that, you're not going to miss any question anywhere, folks. Any question for me about the mood disorder? Let me ask you one question. Sometimes, isn't it, you meet people, they're talking to you normally happy, and all of a sudden they get extremely angry. Have you met people like that? Where do you put that here? People think it's a bipolar, but they are not bipolar. That's an anger management, folks, okay? That's a completely different, because I know a lot of the time people think it's bipolar, you are happy and all of a sudden you are mad. Bipolar mean between mad, sad and happy. Does that make sense, folks? There is no space for anger. When people get it, anger, that's basically they're getting mad. They need anger management for that. But that's not bipolar. All good, folks? All right.
Wouldn't you need at least 2 weeks of depressive symptoms to be able to even diagnose bipolar?
Yeah, there's a timing, right? For bipolar, it usually, you see, are you talking about bipolar 1 or bipolar 2?
I mean, theoretically both, because they both have major depressive disorder. So
They
if they
do.
both have major depressive disorder, you need at least 2 weeks of symptoms of depression before you can
Right.
diagnose it.
So what are you trying to differentiate from?
How you're just talking about the whole anger and people saying that
Yeah,
it's
but
like,
remember, the anger is not one time, right? These people do it oftenly, right? They will all of a sudden get anger. You don't know when they get anger, right? So that's why. But I'm just trying to say, because commonly we think, oh, this person is bipolar because they were normal all of a sudden and they're getting mad for no reason, right? So that's what I'm trying to tell you. It's not, getting mad is not sad or hyper. It's different. Okay, so that's the idea. Any question here? No? Okay. So let's see here. Let's continue. Next page. Now, there's something called postpartum mood disorder or peripartum mood disorder, folks. There's 3 diseases that's super important. Postpartum blue, postpartum depression, and we call postpartum psychosis, 3 diseases. Now, postpartum blue, it's basically about 50 to 85% incident rate. So that's very common. After giving birth, mom's hormones are resetting. Hormone is what makes you think and happy. Whatever you feel, it's your hormones. Does that make sense, folks? All right. So characterized by depressive affect, tearfulness, always if you see most of the time, mothers on the 3rd day or 2nd day, they will just cry. They don't even know why they're crying for. Right. So that's this basically postpartum blue. Fatigue starting 2 to 3 days after delivery, usually resolved within 2 weeks once all the hormones reset back, folks. Treatment supported. Follow-up for depression. You have to make sure that doesn't get worse, folks. Okay. Sometimes what happens, these moms will develop into major depression. We call postpartum depression. 10 to 15% incident rate, formerly called postpartum depression. It basically meets the depression criteria with onset either during pregnancy or within 4 weeks. The only category is, within delivery or within 4 weeks. If it happens, then we call postpartum depression. You treat like regular your major depression, whatever you do at that time. This is also much better, folks. Okay. But the minute they move into this postpartum psychosis, usually they are admitted in the hospital. They don't get to stay outside. They actually be locked up or strained with them because it's danger. Why? 0.1 to 0.2 incident rate. There's a mood, delusion, hallucination, and thoughts of harming the baby or self. Either they can hurt themselves or they could hurt others, right? That's why we have to keep them safe. There's a lot of histories in the United States. One mom put the newborn in the microwave and started the microwave. There's another mom put the newborn on the washing machine and started. And there are so many like this you will come across, folks, okay? Because they don't know what they are doing, right? So that's the idea. Risk factor includes first pregnancy, family history, bipolar disorder, psychotic disorder, and recent medication change, like a lithium use and all these things. You have to be careful. Treatment, look at that, hospitalization and initiation of atypical antipsychotics. If nothing works, you have to shock the brain. That's called ECT. Okay, that's the idea, folks. Okay, that's that. Now, we will talk about antipsychotics. Simply remember, antipsychotics mean dopamine antagonist. It's a dopamine blocker. That's it. All the antipsychotics, whether it's a typical or atypical, it's simply blocking dopamine. Okay, so we should know the minute you block dopamine, prolactin will release. Is everybody clear, folks? All right. So now that's the part. Any question in that section? No. Next, electroconvulsive therapy. That's a shock, ECT, right? Now, if you see here, folks, rapid acting method to treat refractory depression. If a patient has depression and we tried all the medication, nothing helping, this is a choice. So what is ECT? It's basically resetting the action potential of the brain. Does that make sense, folks? So that's exactly what it is. Brain has its own action potential, same as your heart. So that we are resetting that, folks, okay? Depression with psychotic symptoms, catatonia, any acute suicidality, this is what we do. But it has to be done under anesthesia because it induces tonic-clonic seizure under anesthesia and neuromuscular blockade. You have to be careful when they do that. Adverse effect. They might be disoriented for a few days because why? It's basically like, you reinstall the hard disk of your computer, basically. Some files might be deleted, some files, it's gone, right? So that's the idea. Headache, partial anterograde or retrograde amnesia. Sometimes it can take up to 6 months to even get memories, folks. Okay, so that's the idea. There is no contraindication. There is no absolute contraindication, which means anybody can get that. Is that clear, folks? Anybody with depression can get. In fact, this is the only one you could do safer in pregnancy. Because if a pregnant woman has major depression, you cannot give medications. Is that clear, folks? So this is the only thing you could do that, folks, ECT. All right. Next, risk factors for suicide death. This is 100% one question. You will get it in your exam, okay? They always ask you 2 questions. I'll tell you that question. Now, first, let's go through the risk factor for suicide. There's so much risk factor you could see here, but they will always ask you which of the following is the highest risk factor. The answer is previous attempt. Okay, previous attempt is the highest risk factor. If they have attempted before, it makes them to attempt again, folks. Okay, that is the part, okay? The highest risk factor for suicide is previous attempt. But if I ask you what is the most common method, it's firearms, access to firearms, okay? Most common method in the US is firearms, folks. Okay, to guns increase the risk of death. See, that's something important here. Think about it. Not everybody who has the gun will take their life out. Okay, so gun is not a risk factor. I want you to be careful. Having a gun is not a risk factor. It's the most common method. Remember, for me to use the gun, I need to have the mindset of suicide. Is that clear, folks? Right? So the highest risk factor for suicide is a previous attempt. The most common method is access to gun, right? Now, look at this. You could have firearms and also you have to have access, right? So let's say if I live in the house and I have a gun and I have a sibling, if I'm supposed to keep the gun locked in a safe, nobody can access that. So even if my younger brother in my house want to use the gun to kill himself, he cannot because he cannot access the gun. Is everybody clear, folks? So if the gun is not in a safer place, that makes him easier to do it because then he has access to it. Everybody clear, folks? That's the idea, okay? Women try more often, men die more often. We start it, we finish it. We don't stop in the middle, okay? So that's the idea. Now, other risk factors include recent psychiatric hospitalization, family history of suicide, death, and stuff, folks, okay? So these are the 2 questions you get in the exam. What's the highest risk factor? What's the most common method of doing it. Okay, these are the question always comes, folks. Okay, now look at this. Protective factors include effective care for comorbidities, medical, family, all these things, folks. Okay, now there's a lot of protective factor. It's common. The other day, I went to Naperville downtown where I live, just for a walk. It's a park, beautiful park. There's a river next to it, folks. Okay, all of a sudden I see a signboard says, if you need help, call this number. Suicide is not the option. I never seen that board. As soon as I saw the board, I just went in, I walked outside. I was like, what the hell is happening here? I'm not in the mood to suicide today. See, it's creepy even when you read that, right? So then, I was wondering, why did they even put there? Then I was told that sometimes few people try to jump into that river because they want to end their life, right? So, and even in the US, right? Washington Bridge in New York. Is it, Carrie? Is it in New Jersey or New York? The George Washington Bridge. It's between New York and New Jersey, right?
Yeah, it connects like Paramus to the Bronx area.
What's the another name for that bridge?
Suicide Bridge.
It's a suicide bridge. It's a suicide bridge. Guys, that bridge is insane. It's so huge. By looking down, I will die. It's that big. And imagine people jumping from that. It's and the cruise goes underneath it. So you could imagine the deep and the height and everything. Right? So that it's a lot of things happens, that's why even that bridge has that button, like if you need help, you could call for help and all these things, right? So that's the idea, folks. Okay, so that's risk factors. Any question? All right, take a break and we'll continue.